Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 512 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient GBS in parts 508, 509, 510 and 511 of this pharmacotherapy series. I would like you to describe the options available to treat anemia of chronic kidney disease and achieve the goals of therapy in GBS. We will begin by looking at iron therapy. Before initiating erythropoietin-stimulating agents therapy, patient GBS's iron indices should be determined. If patient GBS is iron deficient, as indicated by the transferrin saturation and serum ferritin and other supporting laboratory data, supplemental iron therapy should be administered. If iron deficiency is the cause of anemia, patient GBS may benefit from iron supplementation alone, i.e., without erythropoietic therapy, to increase hemoglobin. Peptic ulcer disease will need to be evaluated as a source of blood loss. Given the poor bioavailability of oral iron and patient noncompliance, oral iron is usually inadequate for repletion of iron in patients receiving hemodialysis who experience chronic blood loss. For the population with early CKD and for patients receiving peritoneal dialysis, an initial trial of oral iron may correct the deficiency because these patients do not have the same degree of blood loss. However, IV therapy will be required to replenish iron and meet the increased demands once erythropoiesis is stimulated with erythropoietin-stimulating agents therapy. Administration of IV iron requires IV access and frequent outpatient visits, which are drawbacks to therapy with IV iron in CKD 3 and 4. A trial examined an accelerated dosing regimen, that is 500 mg given on 2 consecutive days, of IV iron sucrose to address these issues. This regimen was adequate to restore iron stores with only 2 patients experiencing hypotension related to iron therapy. However, IV iron sucrose given 200 mg every 2 weeks for a total 1 gram repletion in CKD 3 and 4 was associated with increased risk of cardiovascular causes and infectious diseases compared to oral ferrous sulfate. Common infusion-related effects associated with IV iron include hypotension, myalgias, and arthralgias. Despite the controversy about the best strategy for iron supplementation in patients with early CKD, current recommendations support reserving IV iron for patients in whom oral iron has failed. Therefore, A trial of oral iron is reasonable for patient GBS. Oral iron supplementation with 200 mg per day of elemental iron should be started to address iron deficiency, if present, and this regimen should be continued to maintain sufficient iron status while receiving erythropoietin-stimulating agent therapy. Many oral iron preparations are available, and their iron content varies, as will the number of tablets or capsules that must be taken per day to provide the required elemental iron. Some oral formulations include ascorbic acid to enhance iron absorption. A heme iron product, Proferin ES, has recently been approved. Heme iron is more readily absorbed. However, a large number of tablets are required to supply the required 200 mg of elemental iron. Patient GBS should be advised to take oral iron on an empty stomach to maximize absorption, unless side effects prevent this strategy. She also should be counseled on potential drug interactions with oral iron, e.g., antacids, quinolones, and GI side effects, e.g., nausea, abdominal pain, diarrhea, constipation, and dark stools. Non-compliance with therapy as a result of side effects is a common cause of therapeutic failure with oral iron. An acidic environment is needed for adequate iron absorption, and acid suppression therapies, e.g., proton pump inhibitors, may limit the absorption of oral iron. Oral iron is a mucosal toxin, and her previous history of peptic ulcer disease requires caution with the use of oral iron. If patient GBS's condition does not respond to oral therapy, as indicated by either persistent iron deficiency based on iron indices or inadequate response to what is considered an adequate dose and duration of erythropoietic therapy, IV iron is necessary. The IV iron preparations currently available are iron dextran, sodium ferric gluconate complex in sucrose, marketed as Ferlakit, iron sucrose, marketed as Venofer, ferromoxetol, marketed as Ferrahim, and ferric carboxymaltose, marketed as Injectaphar. Additionally, soluble ferric pyrophosphate citrate was approved by the FDA in 2015. This iron product is added to the dialysate used for hemodialysis. The dextran products have caused anaphylactic reactions and, as a result, have an FDA-mandated black box warning that requires administration of a 25 mg test dose followed by a 1-hour observation period before the total dose of iron is infused. The dextran component is believed to be the cause of such reactions. The dose of IV iron recommended to correct absolute iron deficiency is a total dose of 1 gram administered in divided doses or for a prolonged period to minimize the risk of adverse effects. For iron dextran, the approved dose is 100 mg increments, administered during 10 dialysis sessions for patients on hemodialysis to provide a total of 1 gram. Larger doses of 500 mg up to the total 1 gram dose have been safely administered during a longer infusion period of 4 to 6 hours. Sodium ferric gluconate and iron sucrose are the most widely used iron products in the CKD population. Both the ferric gluconate and iron sucrose products have been used successfully in patients who have experienced allergic reactions to the dextran products, and evidence indicates that they are safer. 8.7 adverse events per million doses for dextran versus 3.3 adverse events for gluconate. To provide the recommended total dose of 1 gram, ferric gluconate is administered as 125 mg, that is 10 ml, during 8 consecutive dialysis sessions for patients on hemodialysis. The dose can be administered as a slow IV injection at a rate of up to 12.5 mg per minute or diluted in 100 ml of normal saline and infused for 1 hour. Administration of 125 mg for 10 minutes, without a test dose, was determined to be a safer alternative to dextran preparations in patients on hemodialysis and is an approved dosing strategy. Doses up to 250 mg for 1 hour have been administered safely. The flexibility of administering larger doses of iron is an important factor in achieving efficiencies in the outpatient setting for patients with early CKD and those receiving peritoneal dialysis. Iron sucrose, marketed as Venofer, is a polynuclear iron hydroxide sucrose complex. The recommended dose of iron sucrose is 100 mg corresponding to 5 ml during 10 consecutive hemodialysis sessions to provide the total dose of 1 gram. The dose can be administered by a slow IV injection for 5 minutes or diluted in 100 ml of normal saline and infused for at least 15 minutes. As with sodium ferric gluconate, a test dose is not required. Iron sucrose doses of 250 to 300 mg have been safely administered for 1 hour and found to be as effective as sodium ferric gluconate administration in maintaining hemoglobin in patients receiving epoetin. Furthermore, iron sucrose has demonstrated the lowest anaphylaxis at first exposure and during total iron repletion. Smaller doses of IV iron, in increments of 25 to 200 mg, can be administered on a weekly, every 2-week, or monthly basis to patients without absolute iron deficiency. These doses will sustain adequate iron stores, maintain target hemoglobin values, and potentially reduce the required dose of the erythropoietic agent. This regimen is most convenient for patients on hemodialysis who have regular IV access and increased iron needs because of chronic blood loss. Maintenance iron therapy replaces these losses and minimizes the need for the more aggressive 1 gram total doses of IV iron required for absolute iron deficiency. If patient GBS starts on hemodialysis in the future, regular dosing of IV iron during dialysis is the most reasonable way to maintain adequate iron required for sustained erythropoiesis. Iron indices should be monitored at least every 3 months to guide IV iron therapy. This strategy, however, could lead to increased exposure to free iron, which may place the patient at an increased risk of adverse effects, e.g., inflammation, oxidative stress. Pharmacotherapy, marketed as Ferra-Him, is a semi-synthetic carbohydrate-coated, superparamagnetic iron oxide nanoparticle approved for the treatment of iron deficiency anemia of CKD. The small content of free iron in the formulation allows for doses of 510 mg to be administered safely for 17 seconds, followed by a second 510 mg IV injection 3 to 8 days later. Contrary to previous IV iron formulations, a 1 gram repletion regimen of ferrum oxetol can be completed in 2 settings. Prospective, randomized studies in patients with CKD, categories 1 to 5, demonstrated the effectiveness of ferrum oxetol in increasing hemoglobin levels in CKD patients compared with oral iron. Ferrum oxetol presents the same side effect profile as other IV iron preparations, i.e., hypotension or hypersensitivity reactions, including anaphylaxis or anaphylactoid reactions. The carbohydrate coating of ferrum oxetol is suggested to reduce immunologic sensitivity, potentially resulting in less risk for anaphylactic-type reactions compared with the other available high molecular weight IV iron products, e.g., iron dextran. However, Ferrum oxetol has an adverse drug event rate of approximately 0.2%, and the FDA has added a black box warning stating concern for fatal and serious hypersensitivity reactions, particularly with the first dose. Additionally, ferrum oxetol can affect the diagnostic ability of magnetic resonance imaging for up to 3 months after the last dose. We will now briefly look at erythropoiesis-stimulating agent therapy. Recombinant human erythropoietin should be initiated for anemia of CKD in patient GBS if there is no response in her hemoglobin to IV iron. Regular dialysis may improve an anemic condition, but it will not restore the hemoglobin concentrations to normal because the primary cause of anemia is reduced erythropoietin production by the kidneys. Although blood transfusions were once the mainstay of treatment, they are now avoided, if possible, because they are associated with a risk for viral diseases, such as hepatitis or human immunodeficiency virus, iron overload, and further suppression of erythropoiesis. Transfusions may be required in certain patients with substantially low oxygen carrying capacity or substantial blood loss, and in those patients exhibiting persistent symptoms of anemia, e.g., fatigue, dyspnea on exertion, tachycardia. Currently, patient GBS is not a candidate for transfusions based on her hemoglobin of 9.3 grams per deciliter and the absence of significant symptoms on presentation. Androgens raise erythropoietin concentrations and were previously used to treat the anemia of CKD. However, inconsistent erythropoietic response, many adverse effects, and the availability of recombinant erythropoietin have terminated the use of androgens as a treatment of anemia. We will now take a closer look at human erythropoietin epoetin alpha. Human erythropoietin or epoetin, the exogenous form of erythropoietin, is produced using recombinant technology. Epoetin alpha is available in the United States, whereas epoetin beta is available primarily outside the United States. Since it became available in 1989, epoetin alpha, Epigen, Procrit, has provided an effective treatment option for anemia and has substantially decreased the need for RBC transfusions. Epoetin alpha stimulates the proliferation and differentiation of erythroid progenitor cells, increases hemoglobin synthesis, and accelerates the release of reticulocytes from the bone marrow. For patients such as patient GBS who do not yet require dialysis and for patients receiving peritoneal dialysis, epoetin alpha is generally administered by subcutaneous injection. However, hemodialysis patients often receive epoetin alpha by IV administration because easy IV access is established. Subcutaneous administration is preferred because lower doses can be administered less frequently and cost is lower than with IV administration. Starting doses for epoetin alpha administration are 50 to 100 units per kilogram 2 times weekly. For patients being converted from IV to subcutaneous administration, half-life of epoetin alpha is 8.5 hours IV versus 24.4 hours subcutaneously, whose hemoglobin is within the target range. The subcutaneous dose is usually 2/3 the IV dose. For patients not yet at the target hemoglobin, a subcutaneous dose equivalent to the IV dose is recommended. Patients receiving epoetin alpha subcutaneously should be instructed on the appropriate administration technique, which includes rotating the sites for injection, e.g., upper arm, thigh, and abdomen. Darbepoetin alpha, marketed as Aranesp, was approved in 2001 for the treatment of anemia of CKD, regardless of dialysis requirements. Darbepoetin is a hyperglycosylated analog of epoetin alpha that stimulates erythropoiesis by the same mechanism. Instead of the 3 N-linked carbohydrate chains on epoetin alpha, darbepoetin has 5, which increase the capacity for sialic acid residue binding on the protein. The increased protein binding slows total body clearance and increases the terminal half-life to 25.3 hours and 48.8 hours after IV and subcutaneous administration, respectively. Darbepoetin alpha's longer half-life relative to epoetin alpha offers the potential advantage of less frequent dosing to maintain target hemoglobin values. Studies in patients with CKD3 and 4 determined that starting subcutaneous doses of 0.45 microgram per kilogram administered once per week and 0.75 microgram per kilogram once every other week were effective in achieving target hemoglobin and hematocrit values in patients who had not previously received erythropoietic therapy. In patients on dialysis converted from epoetin alpha to darbepoetin alpha, IV and subcutaneous, darbepoetin maintained target hemoglobin values when administered less frequently, i.e., 1 dose every week in patients previously receiving epoetin alpha 3 times per week, and 1 dose every other week in patients previously receiving epoetin once weekly. The approved starting dose of darbepoetin alpha in patients who have not previously received epoetin therapy is 0.45 microgram per kilogram given either IV or subcutaneously once weekly. Patients who are already receiving epoetin therapy may be converted to darbepoetin alpha based on the current total weekly epoetin dose. For patients currently receiving epoetin alpha 2 to 3 times a week, darbepoetin alpha may be administered once weekly. Patients who are receiving epoetin alpha once weekly should receive darbepoetin alpha once every 2 weeks. For example, a patient receiving epoetin 6,000 units per week should receive 40 mcg of darbepoetin alpha once every 2 weeks. 6,000 units epoetin times 2, which is equal to 12,000 units, which corresponds to a weekly darbepoetin dose of 40 micrograms. Epoetin alpha and darbepoetin alpha are generally well tolerated, with hypertension being the most common adverse event reported. Although elevated blood pressure is not uniformly considered a contraindication to therapy, blood pressure should be monitored closely so that changes in antihypertensive therapy and the dialysis prescription are made, if justified. Failure to elicit a response to erythropoietic therapy requires evaluation of factors that cause resistance, such as iron deficiency, infection, inflammation, chronic blood loss, aluminum toxicity, malnutrition, and hyperparathyroidism. Resistance to erythropoietic therapy has been observed in patients receiving angiotensin-converting enzyme inhibitors, although data are conflicting. Rare cases of antibody formation to epoetin therapy have been reported primarily with one epoetin alpha product manufactured outside the United States. Neutralizing anti-erythropoietin antibodies were identified in 13 patients with pure RBC aplasia who required blood transfusions after a course of therapy with epoetin alpha or beta. Treatment of patient GBS's anemia must be initiated, given the chronic nature of her kidney disease and her current hemoglobin. In patients with hemoglobin values less than 10 grams per deciliter, it is important to identify and correct any iron or folate deficiency and perform a stool Guaiac test to rule out active GI bleeding. Iron supplementation is indicated, not only if patient GBS is iron deficient, but also to maintain iron status while receiving erythropoietic therapy. See Iron Therapy section. Although administration of iron alone may improve her anemia, epoetin alpha or darbepoetin alpha may likely be required, based on the severity of her anemia and the progressive nature of her kidney disease. GBS may start darbepoetin alpha administered at a dose of 25 micrograms dosed at 0.45 microgram per kilogram subcutaneously once per week, assuming her iron status is appropriate. See Iron Status section. Another option would be epoetin alpha at a dose of 6,000 units, that is approximately 100 units per kilogram, administered subcutaneously once per week or divided into 2 weekly doses of 3,000 units. She also should be instructed on how to administer subcutaneous epoetin alpha or darbepoetin alpha. Dose adjustments should not be made more frequently than once every 4 weeks for either agent because of the time course for response, i.e., the pharmacodynamic effects on RBC homeostasis. The time it takes to reach a new steady state, when RBC production is equal to RBC destruction, depends on the lifespan of the RBC, which is approximately 60 days in patients with kidney failure. Therefore, it will take approximately 2 to 3 months to reach a plateau in measured hemoglobin. Dose adjustments should be made on the basis of patient GBS's hemoglobin, which should be monitored every 1 to 2 weeks after initiation of therapy or after a dose change. If a rapid increase in hemoglobin is observed, hemoglobin above 1 gram per deciliter during any 2-week period, or approaching 11.5 grams per deciliter, then doses of either agent should be decreased by approximately 25%. If response is inadequate, hemoglobin increase less than 1 gram per deciliter in 2 to 4 weeks, then the doses should be increased by 25%. Once stable, the hemoglobin should be monitored every 2 to 4 weeks. If a response is not observed despite appropriate dose titration, patient GBS should be evaluated for possible reasons for non-response, i.e., iron deficiency, bleeding, aluminum intoxication, hyperparathyroidism, infection. We will now look at other erythropoietin-stimulating agents. The erythropoietin-stimulating agent PE-genes-atide, a pegylated peptide, was FDA approved for anemia treatment in dialysis patients in March 2012. However, PE-genes-atide was withdrawn from the market by the manufacturer after serious hypersensitivity reactions, including anaphylaxis, were reported. Continuous erythropoietin receptor activator, Mircera, is a long-acting erythropoietin-stimulating agent. Sera is twice the molecular weight of erythropoietin from the addition of a single 30 kDa polymer chain into the erythropoietin molecule that results in a considerably longer elimination half-life compared with erythropoietin, that is 130 hours versus 4 to 28 hours. This allows for extended interval dosing of biweekly and once monthly. It has an efficacy and safety profile comparable to other available erythropoietin-stimulating agents. Extended interval dosing agents, such as Sera, have several advantages in patients with CKD 3 and 4, including improved patient compliance, less administration costs, reduced burden on patient from fewer injections given, and fewer outpatient visits to receive IV administration. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 513.